We have those disclosures that are relevant to this presentation. And I'll emphasize that this work was the result of an academic practice grant team partnership, which included participation and support, executive support from the Regional Heart Center, Larry and Rob, critical involvement of the Center for Health Sciences and Interprofessional Education and other stuff in the School of Nursing. And again, point out that Brenda Zierler actually obtained funding from HRSA for this work. And Inpatient Change Team members are listed, as well as consultants from UW-WISH, Team Core, that helped us with a lot of the leadership workshops. So the background, as we all know, heart failure management is becoming increasingly complex, and the population is growing, and particularly at the University of Washington, we receive in transfer and referral of very sick group of people with heart failure. Unfortunately, nationally, heart failure outcomes need to be improved, and a lot of the poor outcomes are a result of poor processes, both nationally and locally, and particularly locally, we understood based on some assessments that Brenda did as a part of the run-up to the grant that our team function is challenged and our care delivery was inconsistent. And it is really important to try to improve care processes because, as you well know, there are a number of papers. This is the one with the nicest graphic, because it's from the BMJ, that demonstrate that medical errors are the third leading cause of death in the United States, and that's probably even underreported because there isn't a medical error selection on death certificates. So drilling down into why these deaths occur, it turns out that about 70% or more are due to miscommunication, errors in communication, incomplete communication, unclear communication. And it turns out that in the airline industry, there's a similar prevalence of miscommunication as the cause of fatal airline accidents. So is there anything we could learn from them? Well, this graphic, which you can look up on planecrashinfo.com, demonstrates that even though the number of airline miles flown, the number of flights has continued to increase over the last 7 decades, something unique happened in the late 70s and early 80s that's led to a decrease in the absolute number of airline fatalities despite a higher volume of flights. And really what this was that the airline industry instituted something called crew resource management, which is a suite of techniques to improve communication, promote team building, better manage workload, and to also focus on technical proficiency. And you see this has had a dramatic effect. Well, in the medical field, there's a medical version of crew resource management that's been developed by HRSA, promoted by HRSA, called Team Steps. And the principles for this are derived from CRM, and Team Steps represents a set of tools and strategies to improve team communication and function. And we've listed some of the examples of tools that you can use to better promote really patient safety. In addition, there's a set of assessment tools called relational coordination, which was developed by Jody Hofer-Gattel from Brandeis when she was working on her PhD dissertation at MIT. And what she did was to study a high-functioning airline and a low-functioning airline that were separated, that actually are in the same, based in the same metropolitan statistical area, and identified the characteristics that help to describe the high function, differentiate the high functioning from the low functioning airline. And really, this can be she developed these 7 domains. The first 4 are related to communication, whether it's frequency, whether it's timely, whether it's accurate, and whether it's focused on problem solving rather than assigning blame, as well as shared goals, shared knowledge, and mutual respect. And this is a very useful tool that's been adopted by businesses, governmental organizations around the world to help improve their team, the culture. And one of the things we're going to show is that in this grant, and this was Brenda's brilliant idea, something that's not been done anywhere else before, is actually to use this tool repeatedly during the course of the intervention to measure the effectiveness of the intervention. So this is, our response was forming an academic practice partnership coordinated through CHISI. Brenda got the funding from HRSA by writing a grant over the holidays 4 years ago, and the grant kickoff was in November of 2014. So I'd like to introduce or bring up Susan to talk about methods and approach.
Grant was to improve team function, workflow efficiency, and improve patient outcomes through using a collaborative change management initiative. To do this, to do this, we used a systematic approach, which included facilitated change management, data feedback, ongoing consultation, and leadership development. And then we formed interprofessional change teams and used mixed method data collection, including validated team surveys and periodic observations of team rounds. The change team and the grant team collaborated to adapt and implement structured interprofessional bedside rounding model. Beginning in 2016, we did targeted team training and utilized team steps, concepts, and cyber simulation, and then we sequentially implemented the cyber model. We continue to evaluate using PDSA cycles and to refine the process. And now I'm going to go over each one of those in a little more detail. Here you see the change team members, and they represent many different professions, and they are frontline clinical leaders. Through grant funding, I was awarded protected time each week to be a liaison between the grant team and the clinicians. The other inpatient change team members you see here actually volunteered their time and efforts each week to help move this project forward. The first objective of the change team was to really explore how staff, faculty, and providers communicate with and relate to one another. And we did this through a method called relational coordination mapping. We mapped out the groups who interact on a daily basis with advanced heart failure patients, and then we drew lines that represent the strength, moderate, strong, moderate, or weak of the communication between these groups. Then we used 2 validated and reliable measurement tools, the relational coordination survey and a team perceptions questionnaire, and we surveyed the groups that are represented in the mapping. Concurrently, we actually gathered data, baseline data, using clinical observations of rounds and began development of a heart failure database. The relational coordination survey assesses communication and relationships between groups. We had a 50% response rate on the baseline survey, and scores of less than 3.5 actually represent or correlate weak communication, and scores of less than 4 represent moderate correlation or moderate communication skills. And the results of our survey showed that we needed improvement in timely communication, mutual respect, and shared knowledge. During the grant, the change team members helped to develop and lead quarterly leadership workshops to understand how to best facilitate change management. In total, we facilitated 17 workshops reaching 329 different individuals representing 13 different professions. In one of the workshops, we learned and practiced a method called liberating structures. Liberating structures are interactive approaches to facilitating change. Armed with the results of the relational coordination and the TPQ surveys, the change team then held a workshop to develop consensus around a goal. We used interactive approach in by liberating workshops called crowdsourcing 2510, and we generated and prioritized our ideas based on this. The end result was that we decided to develop and implement structured interprofessional bedside rounding, and as a way to improve our timely communication, shared knowledge, and mutual respect. So frequently, decisions about a patient's plan of care are made without key members of the healthcare team, the nurse or the social work or pharmacy, and as a result, we often have communication breakdown, and this leads to poor quality care. There's a growing body of evidence that cyber improves clinical efficiency, collaborating behavior, and could possibly lead to improved patient outcomes, although we do need more data on this. So what is cyber? Cyber is when members of all aspects of the healthcare team come together at the patient's bedside to perform rounds. This includes the patient and the family. Rounds follow a structured format, and that allows each member of the team, including the patient and family again, an opportunity to contribute information that's helpful to form a plan of care for the day. In order to ensure our success with development and implementation of cyber, we reviewed the literature and we looked for guidelines and tips from other programs. The hospital medicine services here at UWMC implemented cyber in 2013, and we invited them to one of our leadership workshops to discuss their program and so that they could help us with next steps in implementing cyber for us. The change team then developed a cyber implementation tools, which included a rounding format, a daily plan of care, and an implementation logistics plan. Once we had a plan, we did a small pilot, and that's helped us refine the process, and then we set out to train all the inpatient staff and faculty on 5 Southeast and 5 Northeast. We held 5 4-hour mandatory workshops in which UW Team Core taught team steps, communication, and skills, and participants then practiced cyber using simulation. We also made team agreements for professional and collaborative behavior, and then we implemented cyber in March of 2016. We're going to have Erin come up and discuss our results.
Thanks, Susan. So I'm excited to share some of the results that we've had over the last 3 years as we've worked through this process together. And we've used a variety of modes. We've used surveys, as Susan and Kevin alluded to. We also used observations, and we've also gotten qualitative feedback from both care team members as well as patients and family members. And so the surveys that we did, we started in with a baseline survey prior to cyber implementation and prior to even identifying cyber as the thing that we wanted to implement. And as Susan said, we started with about a 50% response rate on these surveys. And the first one was in the spring of 2015. The second one was in spring of 2016. And then logically, the third one was in spring of 2017. And we saw our response rates over time increase on this, which we were really pleased to see the high rates of response to these surveys. During the third year, we also asked a series of demographic questions, and I think the one that's most relevant here to see for this audience is the one about how long people have been in their current position, and seeing that you have a lot of folks who have been probably here for less than 6 years. And so in terms of both having this change be something that is new for people in their positions and also thinking about sustainability long term, that this may be a pattern that is reflected over time in terms of change and needing to continuously train people in this process to reinforce it and keep it going. So from our surveys, this is going to be the results of the relational coordination survey. You saw the baseline that Susan shared, that we shared back with the change teams and used to identify cyber as the process that we wanted to implement. And we have the different dimensions as well as an overall RC score. And so we've got, this is the baseline that you saw already. And from baseline to year one, and we implemented cyber rounding in spring of 2016 and did the follow-up survey a couple of months after that. And so on all of the dimensions, we see increases. And then from year 2 to year 3, so this is about 2 years after cyber implementation, we see continued increases in the vast majority of these. And we've crossed that sort of threshold from the weak ties to moderate ties in a number of areas, but we've seen improvements in all of these things using this validated survey. And while these are visually obviously pretty different, we also have done some preliminary statistical analyses looking at changes from baseline to year 1. And in all cases, with the exception of shared knowledge, the differences are statistically significant, and including with that RC index, and that's a composite measure that brings together all of the different domains of frequency, timeliness, accuracy, problem solving, shared goal, shared knowledge, and mutual respect. So I think the takeaway on this is that we are seeing changes reflected in these surveys and have a pretty high response rate to be pretty confident in those findings. We also did observations, and Danielle Lavalle's in the back, and we had another person that we carried out observations over a period of a couple of years from prior to implementation of cyber to during the piloting of the cyber, as well as follow-ups. And we observed rounds of 624 individual patients. And what we saw in this is that the length of rounds didn't really change very much, and that's why we don't have a visual on that. But the location of rounds changed pretty dramatically over time. So when we started, we had the majority of rounds occurring in the team room, so nearly 75%. About 25% or just lower than that were in the hallway or in the patient room. And then when we switched to the pilot, we see that we've gotten out of the conference room or team room, we've gotten into the hallway, so we're closer to the patient, but we're still not actually with the patient. And so that was a process of trying to change that, but we're bringing more of the team together. And then from there, we have really pretty consistently shifted, and this is mostly Cards B data, or this is all Cards B data, by the way, so not the CCU, but we've shifted to the location of rounds occurring in the patient's room at the patient's bedside with patients and families there. This doesn't always happen, as you know, because sometimes people, either the patient isn't there, they don't want this type of rounds, but the majority of the time it is now happening at the patient's bedside. And who is actually at rounds or who's participating in rounds has also changed pretty dramatically. So during that baseline period, this is like August to October of 2015, the nurses there less than 25% of the time. It's sort of incidental that they are there. Pharmacists are there most of the time. Social work is there about 50% of the time. And not surprisingly, the attending and the nurse practitioner or APP is there almost all the time, or pretty much all the time. And then as they shift to doing rounds in the hallway, we have the nurses there more frequently. And as we shift to actually being in the room at the patient's bedside, we are seeing approximately 75% of the time the nurse is there with the patient and family, and other members of the team are also there more consistently. And so we've also gotten some qualitative feedback from folks, and I think this is really powerful to read through these comments of what people are saying about what cyber is doing for their practice and patient safety, is that people are saying the plan of care is more clear. There are fewer pages to the MD or APP to clarify. Patients seem motivated by knowing the plan and barriers to discharge. Being part of cyber helps me focus my assessments and data collection. And one person said, this is helping me be a better nurse to my patients. And in that third-year survey, we came up with a question because we really wanted to get at whether or not people think that this is providing value to them in their practice. And so we had this question of, do interprofessional bedside rounds add value for you? And this is a select all that apply question. So for you and your work role, for patients, for family members and caregivers, for the interprofessional care team, or none of the above. And I think the results on this are pretty striking in that while not everybody, but the majority of people see this as helping them in their work role, 94% of people think that this is better for patients and family and providing value for them in their care. And over 90% think that this is helping the interprofessional care team do their work and is providing value. So, and of course we have, there's always somebody who doesn't think so, but it's very minor. So, we had a PhD student working with us over the last few years who was very interested in this, and she was particularly interested in the impacts of this change on nurse satisfaction. So she actually did her entire dissertation looking at this, and she did both focus groups as well as surveys. And what she found in terms of a validated job enjoyment scale, as well as satisfaction, was that job enjoyment went up from before cyber to after cyber, and that was statistically significant, that change. And we also saw that RN job satisfaction also went up from before to after cyber. So, and then finally, in terms of data, and this is an area we're wanting to go further into in terms of patient perceptions and patient outcomes, is what do patients think of cyber, and do they see value in it as well? And so I wanted to read some of these quotes for you because I think that they'll really, for us, they really stuck with us and clarified why we're doing this. So the first being, I wish you would have done this before the transplant. We love it. The second one, and I'll qualify this in a second, is last year was hell and I only saw a doctor once a week. Now I see them every day and appreciate being involved. So everyone in this room knows that they did not see a doctor just once a week. But, or something else was going wrong. But what we do know is that this is helping people to better understand who is on their care team and who's in their room. And so as people come in and out, this is helping with role clarification. And they now know that there is a doctor in there seeing me every day, which was also happening before, but it wasn't clear to them. Other people say, I feel the more eyes on me, the better. It means more people looking for issues. All the people involved were top quality. I was permitted to participate in my treatment, and the conversations were conducted in an open and professional manner, would recommend. And finally, the team approach to care by the cardiologists, nurses, and support staff was excellent. They expressed a genuine care and personal interest in my care and comfort. And so I think those are kind of the reason that we are doing cyber. We do think it is more efficient. We do think that it is helping the team to communicate better. But I think this kind of feedback from patients is something to keep in mind when moving forward. So what does this all mean? So in terms of implications, we think that having the process that we used to implement this was really essential to its success. So we had engaged change teams, we had regular leadership workshops, we had objective measures of progress that we used both to track change over time as well as to feedback to the teams and figure out where do we want to be making changes, where is this working, where is this not working. And that really strengthened this academic practice partnership that we've formed. We also think that we are seeing really positive outcomes from this, and that we are seeing positive changes in collaborative behavioral outcomes like team communication, clinical process and efficiency, and preliminarily around patient health outcomes, but we do need more research in this area. And as Susan mentioned earlier, we have also been funding a database that Todd Dardis and others have been involved with over the last few years, and we are slowly but surely getting more to the point of being able to actually extract and use data out of that database. But so we think that there's a lot of potential there as well. and that our conclusions are that evidence for cyber is growing both here at the UW and beyond. This is something that's happening in other places as well, and we're seeing a lot more in the literature about it. We do need continued, so all is not perfect. We do need continued PDSA cycles to continue to improve consistency and reduce variation in practice. But we do think that cyber is going to be increasingly recognized as the standard of practice for rounding. We have been doing dissemination around this. Our academic practice partnership just won a national award from the National Center for Interprofessional Education and Practice for the work that we are doing together, and received an award for that at a national conference this summer. And we've also been presenting at conferences, working on manuscripts that we're disseminating out into the literature as well, to share what we're doing here at the UW with others, because there's a lot of interest in this. And then next steps. So cyber, as you saw from Susan, there are other units, and you probably know there are other units who've been doing this. So cyber is being scaled up across UW Medicine. This is on the left here, we have the list of all of the groups that are currently using cyber. And then on the right, we have services that are considering cyber, that we've heard rumors are interested in cyber, that people think would be fun to have them do cyber. So it's something that is continuing to grow. And to support this, we've actually become part of a cyber steering committee that meets monthly. Sherry Del Bene coordinates it, and members of all of the groups that have been doing cyber or are interested in doing cyber have been coming together, and we are putting together a toolkit that has different pieces of why would you do cyber, how would you do cyber, how do you train people to do cyber, so that we can learn from each other and not each group be reinventing the wheel. And our vision for this is that it will be both useful locally here as well as posted online and be available to people from other institutions. We've also created, you see an image here of a handout that has been created for patients who are Cards B patients on 5 Northeast that they've been receiving, that explains what is bedside rounds, why are we doing this, what is your role in this. And we have a couple of training videos that I know the fellows have seen are posted on their website. And we are working on a video for patients and family members as well. So there's more to come in this area. And so before I close and ask for questions, I want anybody who has been involved in the grant team or the change team to please stand up and get recognized. There's been a huge amount of work I see you guys back there, and please give them a round of applause.